Good evening, everybody.
Good evening.
हेलो
हाँ हेलो डॉक्टर चतुर्वेदी।
हाँ हेलो हेलो डॉक्टर वर्णवाल।
हाँ
डॉक्टर प्रियंका।
हेलो सर।
देखिए डॉक्टर वर्णवाल हैं।
हेलो
स्पेशलिस्ट।
यस सर।
Hello.
और मेरे कान में क्यों नहीं बैठ रही?
ये चलते नहीं होगी ना ब्लूटूथ में।
उधर चल रही है तो।
डॉक्टर सूर्या।
तो बोल।
डॉक्टर सूर्या।
कौन रखा हुआ?
हैं? हैं?
Dr. Surya, please start the session.
A very good evening, everyone. I am Dr. Jason Surya. I would like to welcome Dr. Rajkumar sir.
ग्लिचेस है, मैं वेलकम करती हूँ। और डॉक्टर राजकुमार जो भी इंट्रोडक्शन का उसको थोड़ी
Yeah, Dr. Surya, are you there? I think there might be some technical problem. So thanks to each and everyone from our team MSCS. Now I request Dr. Rajkumar sir to welcome our guest from our side. Dr. Rajkumar sir.
Good evening, all of you. On the behalf of Team Max, very warm welcome to all of you. Thanks our guest, Dr. T.P. Chaturvedi sir, and Dr. S.C. Barnwal sir, Dr. Gunjan Yadav ma'am, and our start mentor this series, our mentor Dr. Rahul Grover sir from New Delhi, and Dr. Kapil Gar sir, President IDA Northwest Delhi branch, and Nikhil Pratap Singh, Secretary IDA Northwest in Delhi branch, and Dr. Priyanka, Director Max, and Dr. Surya is Regional Head Max Uttarakhand. And a special welcome to Dr. Chaturvedi sir. He is our mentor and my guest, special guest. Good evening, sir.
गुड
evening.
Thank you, sir. Dr.
Now
Priyanka,
I
please
will-
continue.
Now I request Dr. Nikhil Pratap Singh sir from IDA. He is a secretary from IDA Northwest Delhi branch. Sir will welcome our guest. Dr. Nikhil Pratap Singh sir.
Thank you, Dr. Janda. Team dignitaries, eminent speakers, respected guests.
Sir, am I audible?
Yeah,
Dr. Nikhil Pratap Singh
Yes,
sir.
Yes. Am I audible to you?
Yes, sir.
Yeah, Dr. Nikhil.
Thank you, sir. A very bright and cheerful evening to all of you. And as Dr. Priyanka has introduced me as an honorary secretary of my branch.
So please speak loudly.
Okay. I take this privilege to welcome you all to this webinar hosted by Max Dental Skills in association with Northwest Delhi branch. This is the third online series on the topic, which is glide path and magnification, which is an elite part of microscopic dentistry.
There.
Today's webinar is organized to enlighten our knowledge in this view. As I'm presenting as an organizing secretary also, it is my pleasure and honor to introduce our guests and mentors. I welcome our chief guest, Professor T.P. Chaturvedi sir, President IDA UP State. Special guest, Professor H.C. Baranwal sir, IMS, BHU. Session chairperson, Professor Gunjan Yadav, Sardar Patel, Postgraduate Institute, Lucknow. And our eminent mentor and keynote speaker, Dr. Rahul Grover. We welcome you, Dr. Rahul Grover. Please enlighten us about the topic. Thank you.
Thank you so much, sir. Now, I would like to request our chief guest of the session, Dr. T.P. Chaturvedi, sir, to bless us with few words.
Thank you, Dr. Priyanka. And it is so nice that you have started the online session after 3-4 months, and continuously you are doing such a commendable job for the academic purposes. And I'd like to thanks to our eminent speaker, Dr. Rahul Grover, who are there to speak something about the glide path and magnification and microscopic dentistry. In fact, when we are studying the dentistry, especially in the endodontic part, at that time only K file and the H file was there, that is made up of the steel and nothing else. Now, because of a lot of the improvement of the optical devices, we can see such a microscopic dentistry in such a way that it minimally innovate. So excellent topic has been selected by the organizers of the MAC. And I would like to give thanks to Dr. Priyanka, who has given me opportunity to be here as a chief guest. Rest of the person, Dr. Rajkumar is very active, Dr. Hridesh Surya. And again, I welcome Dr. Kapil Garg, President of IDA North West Delhi branch, and Dr. Nikhil Pratap Singh, Secretary of IDA North West Delhi branch, who are collaborating and organizing this program along with the MAC team. And if the MAC team is headed by the Dr. Priyanka, there is no doubt that it will be get a successful, and it is a first series, a first lecture for this session, which is going to start from 23rd January, which is just we are also know that is a birth 125th birth date of the Netaji Subhash Chandra Bose. So you have chosen a good time and good place and a good topic and good speakers. And again, Dr. S.C. Barnwal is there. He is very much expert in the endodontic field, and Dr. Gunjan Yadav is there. So all of the persons who have given me opportunity, once again I would like to give thanks, and I request to all the audience that try to learn something. And although a lot of the things you are aware, but any lectures can add up something at some points in your career, in your clinical practice. Thanks again, Dr. Priyanka. Thanks.
Thank you so much, sir. Now I will request Dr. Barnwal, sir. Sir is from BHU. He is a professor in endodontist. Sir, please bless us.
Okay, Dr. Priyanka. I thanks to Team MAG Dental Skill, especially Dr. Priyanka Yadav and Dr. Rajkumar Singh for inviting me here as a special guest. It is my first time to attend this MAG series lecture, and I also thanks to the President Dr. Kapil Garg and Dr. Nikhil Pratap Singh, Secretary for the IDA West Delhi branch. I thanks also the the speaker, Dr. Rahul Grover, for the choosing such nice topic for the glide path preparation and magnification, which increase the illumination and like the uh, visibility and ergonomics in dentistry that will be very poor in now. Most of the dentists is lacking the ergonomics, and this loops, magnification and microscopes, and even the most important thing is a glide path. Glide path is a key for the any root canal success. And I thank Dr. Gunjan, who is also here for as a chairperson. And this lecture is definitely very beneficial for the all the clinician student, PG student, for their in practice, and they, because the Dr. Rahul Grover, I know that he is very wonderful speaker and very good teacher for that. I thanks to again the Max Dental team.
Thank you so much, sir. Now I must request my teacher, Dr. Gunjan Yadav, ma'am. She is the chairperson of the session. Ma'am, please bless us.
Thank you, Dr. Priyanka. First of all, I would like to thank everybody, all the organizers of MAC, to inviting me here on this platform. And this is the very first time, but I'm glad and I'm so enlightening to know that you people are doing so well. Regards to Chaturvedi sir and Banwal sir. And it's very nice to see my students, Priyanka, Dr. Nikhil, Kapil, Dr. Kapil, and everybody doing so well in the field. And it's very heart touching and very nice to see them progressing in the field. And I would also like to congratulate Dr. Rahul, who's here on the platform to speak. And I am sure that this would be very enlightening for all of us and for all those who are present as delegates. Best wishes to one and all. Thank you so much.
Thank you so much, ma'am. Now we will, I guess, our participants from India, and we have some international participants also. So before start the session, now I will request Dr. Rahul Grover sir to introduce himself and start the session.
Thank you so much, Priyanka, for this opportunity.
Thank you so much, sir.
Thank you.
Sir is our star mentor of today's New Year series. This is the first series, and sir is our expert mentor. Thank you so much, sir.
No, thank you. I'm very grateful for this opportunity, because I feel that the only way to grow forward, the only way to go forward is to grow forward. And that's the only way I feel that that's how my journey is. And that is what I'll be teaching. All the slides that I've made is basically how I have evolved as an endodontist from 2008, when I cleared my MDS from DAV Dental College, to where I am now, the changes, the mistakes, all that I've made. So all this I'm going to be telling you. The time is less, of course, but then I hope that if I can inspire even a few today to take up this change, my webinar would be a success. That is what I personally feel. So let's grow forward, all of us. May I share the screen now, please?
Interrupting you. Actually, we would like to share our certificates as a token of appreciation to our guest. Dr. T.P. Chaturvedi sir, kindly accept a small token of appreciation from our side.
Thank you. Thank you.
Thank you, sir. Dr. Barnwal sir.
Thank you, Dr. Priyanka.
Thank you, sir. Dr. Gunjan Yadav, ma'am.
Thank you so much. Thank you.
Thank you, ma'am. Dr. Rahul Grover, sir.
Thank you for this. Thank you.
Sir. Dr. Kapil, sir. Sir is not here. Dr. Nikhil Pratap Singh, sir. Dr. Rajkumar Singh, sir. Dr. Hriday Surya. Dr. Arpita Singh. Dr. Shakti Goyal. Dr. Deval Arora. Thanks to all of you. Now, sir, please start your session. Thank you so much, sir.
Thank you. Academic feast is what you said, huh? Good. Okay, thank you so much. Dr. Priyanka, I would just ask you before I start, is my voice clear and is the screen clear to everybody?
Yes, sir. Yes, sir.
All right. Thank you so much. Once again, thank you, Dr. Gunjan. Thank you, Dr. Priyanka, Dr. Chaturvedi, Dr. Banwal. Thank you so much for your kind words. Grow forward and go forward is what I firmly believe in. This is the journey of me as an endodontist from 2008 after I cleared. You know, I used to hear this when I was in my post-graduation, and I remember my HOD, Dr. Bogra and Dr. Vinita Nikhil, Dr. Vijay Singh, that they used to say these lines quite a lot, that, you know, Rahul, you're going to be, your eyes are going to be treating what you will be seeing. So a lot was there. Dr. Priyanka, can you mute everybody else except
सर म्यूट हो गया. हेलो. अनाउंस करो, सब म्यूट हो जाए. Kindly. Hello.
Sorry for technical error.
Yeah.
Just give us few minutes.
The host wasn't allowing me to unmute myself, so I said the powers of the host.
Yes, sir. Yes.
Yes.
It's okay.
You can mute all participants except speaker.
Yeah, thankfully don't mute me today. So here we go again. All right, thank you. Welcome once again from that faux pas of Zoom. It so happens an online platform, learnings and teachings. So as I was growing up, this line was always told to me, you will treat what your eyes will see. And 2008, I wasn't doing magnifications. So I am going to be absolutely honest with you in my journey. I wasn't doing the magnifications. And I used to basically believe that this is a statement and we could only treat so much. Believe me when I say so, sometimes, and even in my post-graduations, finding an MB2 was the moment of the day, was the red letter day of our life. It was like a birthday, celebrations for us. And hey, I found an MB2. I found a mid-mesial, a 3-rooted premolar, never did in my post-graduation, never did. Because why? I could never see those systems. And there was a reason for that. The reason was that we live in a visual void, you know. Sometimes I used to ask myself, hey, I don't need a microscope. Why do I need a microscope? And this question was with me till 2018. I did not have a microscope in my practice. And I used to tell myself, hey, I don't need a microscope. I know how to do a root canal. I'm able to do it. Because a root canal is a blind procedure after all, right? How much can you see in a root canal? How much can you see? There's nothing much to see down there. That's what people used to tell me. So when I bought a microscope, and after 2 years, I started preparing to give a little lecture, to pep talk to the fellow dentists in Faridabad who used to come to my clinic, or who sometimes used to refer a patient to me. So I used to say, why don't you buy a microscope? And, you know, it was like the questions coming back to me. They were saying the same lines, what I used to tell myself. Yeah, blind procedure, and after all, there's nothing much to see down there. And a lot of times the experienced dentist will say, look, Dr. Rahul, we know how to find a canal, but we want to refer this patient to you. And when I used to talk about that, doc, how do you find the MB2s and mid-mesials? So a lot of times I used to say, MB2, mid-mesials, I mean, they were like, who finds them in today's world? So, you know, it is how we have been taught. It is how we have we have grown up. A lot of times in our practice, as we have grown, that a lot of times the failures are not attributed to these mid-measles or MB2, but there are a lot number of cases that you will see are attributed to such failures. And most importantly, we used to always say that this is a tactile-based procedure, nothing much to do here. In 2016, I think this was the defining moment of my life. I attended a webinar, a physical conference in Mumbai, and Dr. Cliff Ruddle had come to Bombay. And this is my picture, you know, he was just walking, it's just a huge screen at the backdrop, and he had come to India talking about pro tapers and all. So this moment, when I captured him, he was only talking about two things to the audience, only two things to the audience. He was talking about how to make a glide path. And when he shared his picture of him working with the assistant and a microscope, it stayed with me, completely changed my perspective. Not that I bought a microscope in 2016, but it got me thinking that, okay, I'm becoming comfortable in my practice, but I have to do something different to change the way I practice. Visual void is so important because we have always got less visual information. We are always tactile. We always try to feel the orifice. We always try to feel a canal. We always try to move our fingers. So MB2 would be like this, like a Bharatnatyam dance. You know, this is MB2. This angle is MB2. This angle is mid-mesials. This is the problem because our eyes are not able to give us the information that what. And sometimes, you know what, and this has happened with me. I still remember second year post-graduation, I got a case of an upper maxillary, it was a lateral incisor 2-2. It was referred, and one of the first few early cases that was given to me. There was a slight calcification in the chamber, and I asked my senior at that time that, sir, I'm not able to find the canal. You know what he told me? He taught me a lot of lessons in my life, but he told me that, have you felt the drop? And I was like, no, sir, I haven't felt the drop. He said, then go on, you will feel the drop. And I did feel the drop. And sometimes when you do feel such drops, you are somewhere here. And this is what happens. A case referred to us by someone trying to feel the drop. And when you feel the drop, you're going to be doing somewhere else because the canals are not here, my friend. The canals are somewhere at a different place. So you seal it, and then you find the canals, the MDs and the mesobuccals and the mesolinguals are at a different place because the chamber is calcified. And the same thing happened with me. Sorry, I don't have a picture of 2007 with me of my lateral incisor because I perforated the lateral incisor. And the tooth went for extraction. Patient didn't mind much. He was just paying 600 for a root canal, and life moved on, and I was comfortable in what I was doing. So, you know, treatment has to become predictable. Sometimes it is unpredictable. And sometimes when we feel that we have found something, it is luck by chance. That's what I call it. Hey, today I was lucky enough to find an MB2. I was lucky enough to manage a ledge. I was lucky enough to find a mid-mesial. So this luck by chance, you got to control a lot. So you got to keep the factor. You got to keep the ball in your court, not in the other court. And that is how you can actually become a more skillful endodontist. You can become a skillful practitioner. And by the way, it is not that an endodontist should be using a microscope. If you're doing the root canal treatment, you need to have a microscope. It is very important to work with this tool because let me tell you, it is going to change the course of your practice for the next 10, 15, 20 years, whatever years you have left of your practice with you. Mark my words, it has done to me. So my question is, how small is small? You know, how small is small? I mean, the ability of an optical system to distinguish two different things is basically how small is small. So let's do a small test, everybody. The screen, I can't see all of you right now, but all I would want you to do is take your finger and bring it close to your eye. And when you bring it close to your eye, try to make it more close to your eye. And after a while, you will actually see a strain developing within your eyes because you want to see clearly, but it is too close. And this is the resolving power of a human eye. It can only differentiate 0.2 mm. And so for most people, 2 points which are closer than 0.2 will become only one circle. So An optical microscope, a dental scope, let me call it a scope because I'm so used to calling a dental operating microscope as a scope. So a scope can raise the resolving limit from 0.2 mm to 6 microns. To 6 microns. Now imagine that. The fact, look at the fact here. This is a fun fact for me. When you lute your crowns, or when you do any luting procedure, the allowed thickness is between 20 to 25 microns. So your microscope can have a resolution power or even less than that. So that's how important it becomes in your practice. And our eyes do get tired after a while. Yes, we work, people who are working without magnification or with loops tend to have, I still remember, I think I told Dr. Kapil once when he was here and he was trying a loop, he told me that it gives him a headache. Because loops tend to give you a headache if not used properly. And the only way to remove this is by coming close to the patient. In today's time, how much close can you come to the patient when you're working? Just because you want to see clearly and have more depth of definition. So simple answer is you can't do that because the eye's ability to refocus as you decrease, as I'm going to decrease this distance, is what happens. Your eyes will start having an eye strain because your eyes are now converging at the same point. That's why a lot of people who wear loops will not use it after a while. Of course, there are loops which are definitely much better, which will not give you these eye strains, but people who generally start their journey with a loop which is very, very economical in the range of 7,000 to 8,000 rupees would tend to not use it because of this problem of eye strain. This is the journey. This photograph is so important because this is the journey towards comfort. We're all going to age. I'm 40 right now. And I have another 15 years or maybe 20 years of practice with me. And I can't bend and work now. I need to be in my comfort zone. I need to be sitting straight. And I need to make sure that my back muscles are always relaxed. And this is what happened from naked eye to a person, to a dentist, really looking down towards the patient just because he wants to see more, to the loop, to the microscope. See how the back posture changes. So this is a journey of ergonomic, as very rightly said by Dr. Bernbal, that this is an ergonomic part of this. And this is the most important part, why a microscope makes you practice for a longer time, because, hey, you're more comfortable. It is as simple as that. Objects which are very close to the eye. What happens when you get an eye strain? Your ciliary muscles are flexed. The interocular lens of the eye is bulged. The extraocular muscles are flexed because they're all converging towards one point when you're wearing a loop. And this is a very simple loop, the simple optics loop that you get, which is 2.5, 4.5, without any high-end, light optics in them. And that's why people will stop wearing loops after a very short time. Now, when you have objects at a distance, like in a microscope, everything is relaxed. The ciliary muscles are relaxed. The interocular lens is flat. It is not bulging. The extraocular eye muscles are relaxed. And you're working comfortably because you are focusing at infinity. You're not converging. And that is why when you work, you are more comfortable working with a microscope. Now, loops basically were developed to address this problem. When people were trying to go too close to the patient and the eye strain used to happen, then the loops came. But when the loops came, they had their own problem, that they started giving eye strain to the patient, to the dentist. And to overcome this, there's one term which you must understand is the depth of field. To overcome this problem, basically the depth of field problem. Now, what is depth of field? Depth of field is the ability of the lens to focus on objects near or far without having to change the loop position. Just to give you an example, in this picture, you can clearly see that the upper image is more clear than the lower. In the lower, only one part is focused. So when you're working, you want the depth of field to be there. That means you need to be focusing on everything and not just on one thing. So loops basically which have a high, like these Galilean loops or the prismatic loops which you get. So Oroscoptic is a very well-known brand across the world. It makes you loops which are based on Galilean and prismatic concepts. So the concept is that when you're looking through a loop, it is not converging, it is parallel. And based on this, the Galilean system where the optics are parallel and not converging, the first microscope was evolved. Now, when you're looking through a microscope, there is no eye fatigue. because you're focused at infinity. But when you're looking through a loop, you're converging at a single point, and that's where you stop wearing a loop after a while. The dental operating microscope, which was introduced by Dr. Gary Carr. Guys, please note down this name, Dr. Gary Carr. The first thing you should do when this webinar is over, go to the YouTube channel and subscribe to him if you want to start your journey on operating microscopes. So he is the real guru, the father, the mentor of dental operating microscopes. In 1999, he introduced the Galilean optics, basically, which meant that optics in which you focus at infinity into the microscope, and it had a magnification changer. So you could change between different magnifications from 3.5 to 30. It was basically a stable, it was either had a mount wall on a ceiling, or it had a floor mount, angled binoculars. It allowed you to do sit down dentistry. And it also had a parallel, an assistoscope, basically a scope for the assistant. So now you could actually sit, look straight, and without coming too close to the patient, you could work in your comfort. And what are the advantages? Now, when I say a microscope-based practice, I mean an integrated microscope dental practice. You will see a number of times, people will buy a microscope and then they will use it as and when required. So they will do an access opening, and I've seen it, a lot of people when I used to work, they used to bring the microscope with them when they were seeing an access opening. When the access opening was done, the microscope used to go back to the position, and they used to start with their hands and the normal conventional way. So an integrated microscope practices when microscope becomes a part of your all routine dental procedures. This is the main key. Almost all dental procedures require a resolution beyond 0.2 mm. So which means you no longer can depend on the naked eye to make it a success. All these things, crown margins, root canal locations, caries removal, furcation and perforation repairs, post placements removal, retreatments, veneer placements, finish lines, even as something as a finish line check, should be done under the microscope so that it can give you, because you have to understand, you cannot rely on your eyes, because your eyes, you have to know this, that your eyes can't see beyond 0.2 mm. And the best part of having a microscope is that it becomes an ergonomic practice. That's the first thing, that is the most important part, that you become more comfortable in your practice. Yes, there is a learning curve to it. It is not a straightforward jump, but it takes a while. But that learning curve is a journey in itself, because you realize what you need to change in your practice to have an integrated microscope setup. Then it is a healthy practice culture, because remember, it is not just you, it is your assistants also who are all the time with you, standing on 2 feet. Half of the time, all the dental assistants have varicose vein problem because all the time standing. So remember, it's a healthy practice culture, what you need to develop around your team. And if you are as good as your assistant, that's what I always believe in. And if your assistant is comfortable with you for a long time, years to come, then this is a very healthy sign of a practice which is growing together, a practice which is looking after each other. And I can tell you this, and I'll tell you why. A number of times when our clients come back to us for a routine checkup or for some other issues, they would look around, they would look at the back and say, okay, Dr. Rahul, aaj Sanjeev nahi hai practice mein. So, they remember who was your assistant when they were working on, because that's what we do. We introduce our patients to our team that, hey, this is Sanjeev, so and so forth. So my chief assistant who helps me around. So when they come back again and they find the same person there, they're kind of happy about it because they like it. They know that this person sticks with him, and it is because we try, and this is, and I'm also learning as I'm growing in my practice, that we have to look forward, we have to look out for each other, and a microscope is the best way because your assistant also sit and practice with you. Stress reduction, the stress that you go through when you're doing an access, the stress that you go through when you're trying to do a perforation repair is immense. And it is only going to be helping you when you can actually see what you're doing. Imagine driving a car in the night without your lights on. I mean, God forbid, that is a very stressful condition. And that's it, lights on. I'd say lights on. And lights on means it's action time. Healthy posture and a better eyesight. because your microscopes have your, if I wear specs, my number is -0.2, and that setting of 2 diopters, -0.2, -2 diopters is already in the microscope. So it is a better eyesight. I'm not straining my eye when I'm looking through it. Elimination of a burnout. No longer you will feel tired after doing long cases because you're comfortably sitting. And most important, I feel that this is what you will learn as you will grow with the microscope practice. It makes you a better skilled dentist. And you will see little 1 or 2 slides have put how you become lesser failures and more fame. And believe me, this, I wrote this line of lesser failures and more fame because after buying the microscope, so Faridabad is not a very big place. It's a small town in Delhi NCR. As my practice started to grow, initially there were a lot of people who used to say, okay, Dr. Rahul has got a microscope, it's a new toy. And I used to feel, yes, it's a new toy. Slowly my referrals started to increase. Now every week I get 2 referrals from my neighboring dentist. That they are facing a problem with the root canal, and they're very clear about it. They will refer me because they know that they can't manage this case, or they have done a root canal which is maybe failing, or they have some issues. So your practice will start becoming more of a referral practice. And when I say referral practice, it is the best way, and a lot of senior practitioners will agree, it is the best way to go forward, because when a patient comes to me with a referral from another dentist, they will not say anything to what I'm charging them for. And we charge handsomely for a root canal. For just to give an example of how much we are charging, we would be charging for a molar, let's say a 3/6, about 12,600 to 13,000 rupees for an RCT, which includes the core buildup. That's what we charge. And slowly my clientele has become like that. Slowly my clientele has become, and for a referral, if I'm doing a retreatment with a patient in which there is no file removals, we are around 15,000 rupees without core buildups. And patients appreciate it because they see a change, because they see a lot of new technology which is helping them out. There's a lot of clear communication between me and the patients. So this is basically how you take your practice forward. You're not taking it to the masses. Please remember, it's a niche practice. And that's how microscopes help you. And the best time is, because you're more healthy, you get to spend more time with your family. You work a little less, but you make the same amount of money and you come back home on time. And family is very important. You don't want to have burnouts. When you come back home at 8 o'clock, my kid comes to me, hey dad, let's play. And I say, okay, you know what, I'm tired. I just had a long day. What's the point of working if I have to tell him? The only few hours I meet him in the night. So this is how you need to look forward to grow. And this is not how I was in 2008. This is how I've evolved. And that's why I said, this is a lot about my journey sharing with you. Now, moving on, this is how we practice. Now, this is my new assistant here. She joined about 2-3 months back. And this is how we train. This is my second assistant sitting on my chair. And this is a ceiling mount microscope. So you can see with the arrow there that this is a ceiling mount microscope. And on the back, you can see a screen in which I'm playing the video of Dr. Gary Carr training his assistant. So his assistant is Joy. She's been, not the Joy, but the Joy is her name. And she's been with Dr. Gary Carr for donkey years now, I think almost more than 25, 30 years. And this is what I want. I want one or these 2 people to stay with me. And this is what we do in our free time. We would make them sit side to side comfortably, and they will start practicing the change of instruments. And you will see when I in the later slides. But the microscope that you must have, I feel, for people who are about to buy or who might buy, you should look at a ceiling mount, provided you're not on rent or the place belongs to you, because you need to actually have fasteners going up in the ceiling. The reason for having a ceiling mount is there is a lot of space that you don't clutter with the microscope, because a microscope is like one big person, giant 6-foot guy standing right next to you. So you'd rather have him mounted on the ceiling, gives you more space to walk around in and around the operatory. Now, what is the anatomy of a microscope? Now, this is where it gets a little boring, because I wish this was a physical webinar, a physical lesson, and I would have actually made you do hands-on on microscope. So you have the eyepieces, the diopter correction rings, the binocular, the beam splitter, the iris, the body with the magnification changer, and the main part is the lens. So you look through an eyepiece, that is, you look through an eyepiece, then you have the diopters where your specs the number, whatever specs you have, is dialed into the diopters, then through the binoculars, which can move, beam splitter, where the light will divide into two, iris, which controls the light, the body, which has the magnification changer, and the lens. Now, if you look at the body, which has the magnification, there are certain simple swivel switches where you can change between different magnifications from one to another. Now, the eyepiece is very simple. You can look through it. It comes with different X. It's a 6.3, 10X, 12.5. Different companies will give you different. So what we have is a 12.5. And it has rubber cups which pull out, basically, because some people don't want to work with the specs. They would take off their specs and then work, which means if I take off my specs now, I would set it to -2. And if I'm working with my specs, I would set it to my diopters to 0. And the rubber cups help, and I'll show you how. Now, this is a very important picture. Why the rubber cups are very important? Because remember, you bought this expensive piece of machinery to sit and work comfortably. If the rubber cups are not there, your eyes will keep on blinking because the eyelashes hit the eyepiece, the eye cups. So when you have an eye cup which is protracted, which you see in the last picture, you can see it is nicely covering the eye, and the eyelashes don't interfere, and you can work comfortably when you have these nice retractable eye cups. Binoculars is basically, you all remember your 12th class when you used to do those dissection and look at the onion peel skins. Basically, binocular is that. Now, the binocular of the microscope can change. It can go into different directions. It is all to give you comfort. Now, it is important to understand that when you will start with a microscope, you would be changing. Now, let me ask a question here, just to make it more interesting. On the chat box, guys, can you just tell me your most preferred working position? And I'm talking in the hour clock, 9 o'clock, 10 o'clock, 11 or 12. So just, I want to see on the chat box. So fire at will at the chat box, which is your favorite working position? And I would just want to see what happens in the chat. Questions will come. How to negotiate a canal when there is sclerotic dentine, I understand, will come later. 12, 12, 10, 11, 8, Dr. Preeti says 8, Dr. Bimal 11. So a lot of you are working 9, 10, 11, 12. Fantastic. These are good positions, but as you will practice 10, 11, 10, 11, as you will practice, thank you so much for your participation in the chat box. As you will practice, let me just close down this chat box. Thank you. As you will practice with the microscope, you will realize your working position will be almost exclusively between 11:30 to 12. I mean, that's, if I can put it in a more precise, between 11 and 12. That's it. You won't be even going to the 9 o'clock position. So, and it is what makes you really comfortable, because that is where you are working most of the time, sitting behind the patient at 11 and 12. That really makes, now this is the beam splitter. This is a very important part of the microscope. This is actually a beam splitter of my microscope. I opened it up because the images that I was getting from Google weren't very clear. So I opened up my beam splitter. So you can see two rings here. The beam splitter has one job. As the light will travel down, it takes one to the patient, and it takes one to the assistant, and one to the camera. So yeah, that line that someone has drawn is not very clear. If you want to draw a line, draw one towards the left, one towards the right. That is where the light beam splitter, that is the main role of beam splitter, taking one to the patient, one to the assistant, one to the camera from where you record your pictures. Coming next, Dr. Priyanka, can we take off this line? I'm sorry, I'm not very good with these lines. Okay, moving on. Now, there is another important part, which is the dual iris. Now, my microscope is a Labomed microscope. As you can see, it has a dual iris. Now, basically, the iris is that it controls the light entering the lens, basically from the beam splitter. So you can see on the left picture, the two eyes are completely open. And if you move the center picture, that is, there's an arrow with which you move through it, you can actually close the light. So you can actually decrease the light, or you can increase the light, basically depending on how much you want to see when you want to take a picture of what you're recording. That's the main purpose of having a dual iris. Now, it is all about ergonomic, and this is the Carr extender. It is exclusively to Dr. Gary Carr, but a lot of other microscopes are now come out with it. Now, you can see the picture on the right. Even if you buy a microscope, you might become uncomfortable on day one. Because if you look at the top picture, you can actually see how this dentist who bought a microscope still hasn't figured out to configure the microscope. Because if you're working at this angle, you will always be having backaches and neck ache. It is as good as working without a microscope. But in the second picture, if you see, look how the microscope comes to the dentist. And this is only possible if you have an extender or an angled beam splitter, which takes the microscope towards you. So from this, you become like this. That's the beauty of a car extender. Now remember, this picture is very important. This is what you want to do. You want to be sitting straight, the microscope towards you, and that is how you want to be working. So the neck angle, the flex angle here is what really, really matters. When you, so this picture will always should stay with you when you work tomorrow on your patients. Just try to ask your assistant to click a picture of you when you're working, share it with me on my number, on my WhatsApp, and let's see how you look at when you're working at your patients. Now look at this picture. Let me, Dr. Priyanka, can you take off this line? Because let me see if I can take it off. Yep, can I erase it? Fantastic, I erased it. Thank you. Yeah, this is discomfort versus comfort. The most important two slides. Everybody is not as lean as Dr. Kapil and fit as Dr. Kapil. People, I have a little tummy going in my 40s. So when I work, I want to be comfortable. So on the left side, this is a fitter, a younger dentist working. On the right side, this is a 40-year-old like me dentist working with a little tummy. The key is to sit straight. Look at the two angles in the discomfort and comfort. That is the whole point. So even when you buy a microscope, that might be the worst decision of your life if you don't know what to buy in a microscope. And that is where you need to understand the company, what parts they are giving you. So an angled beam splitter with an extender is a must when you buy a microscope, because it actually makes you sit straight. And this is what happens when you buy a microscope with a beam splitter, with an angled one and an extender. Different companies have different names to it. So whatever you decide to buy, you must go and take a demo, sit, see how comfortable you are on a patient. And that's it. If you buy a microscope wrong, you will be really, really cursing, I think, me for the rest of your life. So do know what you're buying, know what you're getting into. Now, this is another topic altogether, very close to my heart. We are planning to have a hands-on on this very soon. I call it the noise and distraction. When you're working under a scope, this is what you end up seeing. This is what you're seeing all the time. Everything around your eyes is distraction and noise. So when you work under a microscope, why I said it's going to make you a skilled dentist or a skilled endodontist, because you need to work exclusively under a rubber dam. That's it. Between this and this, which is more comfortable to see to your eyes? The one which has a rubber dam on, because this is it. You are not seeing anything else, no tongue movements, no saliva. So working under the rubber dam becomes mandatory if you are buying a microscope. And let me be very honest with you. Do you think I was working with a rubber dam in 2008 in my PG times? Yes. 2009, yes, a bit. 2010, no. Because when I used to go to my visitings, rubber dam was like, who uses a rubber dam? More number of patients, more time to make money, less time, jumbled up practices, no time for rubber dam. Never had it. It was only in 2014 when I decided that if I go to my visiting, I would carry my rubber dams, I would carry my ultrasonic tips, and that's how I work. And from doing 5 patients in a visit of about 5 hours, from about 4 to 9, I would only do 3 patients. It was a little difficult initially because I used to feel that I'm working less. Yes, the patients, I also started taking more time on the patients, but this was the journey I was willing to start on. And this is the most important part. Rubber dam dentistry is a game changer in your practice. Mark my words when I say so. So training the staff. Now, this is a very important video because when you're free, you need to train the staff members, how they're working, what they need to be doing. And this one exercise is very important that I'm teaching my assistants on the left, how to change a mirror when you're working. Because when you're working, a lot of time can be wasted in going from right to left, A lot of time is wasted when you want the patient, because the patient is not moving, he's wearing a rubber dam. But if the mirror is fogged all the time, because you're working with an air rotor, you need to be working, you need to have a swift movements of your mirrors so that you can actually work more efficiently and do your best, because this can be stressful under a microscope when your mirrors fog. So there's a new type of mirror which we should be having in a practice very soon. It's called a Yero, YERRO. It's a Google it. It's a very interesting mirror. It goes to your high back suctions and it actually keeps on defogging on its own. A very interesting mirror. It's a little expensive, but a good buy for people who are working under the microscope. Now, as I said, your eyes will treat what you are going to be seeing. Pulp stones are a huge impediment in your practice because you sometimes don't know about a pulp stone. The pulp stone is not budging. Half the time you keep on feeling that there is a restriction in the canal and you end up. So when you remove a pulp stone, voila, there's a different anatomy altogether below a pulp stone. Just to show you a small video of a pulp stone, that how it should be removed, how interesting and how comforting it is to remove under a microscope. Now you can just see this video. This is StarTech tip. This is a video about 2 years old video. I was fond of putting music into my videos at that time. Sometimes the stones will not move, but that's fine. You can go to something different. And here comes the moon's burrs, a very interesting. These burrs are also available on pink, blue, by the name. I think write in the chat box. I use the comet burrs now. So this is important that you need to be in control, and there you can see the head of the pulp stone being exposed, and I will now tease it out with the help of an endo DG16. There it's now able to move it. The coronal pulp is attached to it. And if I would have tried to find my glide paths like this, I would have gone mad. I would have separated a file or something, done something really silly. And as soon as you take out this pulp stone, you can actually start appreciating the MB1s and the MB2s, which are going to be there. There you can focus it. So this is the beauty of working in a microscope. A lot of time, number of times, you are the boss when you're working like this. Moving on again, few clear, and this is my 2019 pictures where I started learning a little bit about photography to make it for presentations. That how clear. And I used to read this word when I used to see little posts on Facebook, that squeaky clean canals, squeaky clean accesses. This is a squeaky clean, where everything is clear to you. Even when you're hunting for MB2, once you go through the trough of an MB2, the MB2s are so, they're just staring at you. They're just looking at you that, okay, do what you have to do with me. I'm right there in front of you. And that's the beauty of working with a microscope. Of course, now when you work with a microscope, it increased my skill set in my conservative part, in my this part also, because it is not just endodontics, it is about you're doing your a good class 2s also, and it really helped because then, because of the microscope, I started doing more of multiple teeth isolations. This is a case from 2000, not sure, I think 2020, 2019. But just to show you that this is one of my earlier cases when I started doing everything the right way. Of course, there is always a platform to learn more. That rubber dam is the key, as I said. So you can actually see everything. You can see rubber dam inversions if done properly. You can see the caries. You can see how you need to tuck the rubber dam with the rubber floss, with the retraction cord or a Teflon tape, expose the gingival margins, leave some unaffected, modified Hall's technique. So you can even see in a microscope whether there is a gap between the matrix. This is a payload system from Dentsply. You can do the final checks, and this is how it looks once it is finished and polished. So this was one of my first few cases of multiple teeth isolations with rubber dams, and all done under the microscope. It was a sheer joy to do these cases because I felt good. It's like a kick that you get because you remember. Your biggest fan. Okay, guys, I want to know in the chat box again, a little 30-second break from the routine lecture. Who is your biggest fan? FAN. Who is your biggest fan? In the chat box, I want to know who is your biggest fan. That's a very important question. Let me see what you people write. Okay, can we see who is your biggest fan? Anybody, please? I don't see the chat box going. Dr. Swati says myself, and that's absolutely the correct answer. Myself, me, myself. Niti says my nephew. So your biggest fan is you yourself, because you have absolutely got to love yourself for who you are. We all have imperfections with us, and you got to celebrate those imperfections, because if you don't love yourself, you will not be able to take the next step. And this is where I started actually loving my work. I started showing up for work early with a happier face, not कि मुझे clinic जाना है सुबह, but I've started enjoying more of my work. And this is what microscopes can do. And even anesthesia. Now, a lot of time people say, how do you give? Yes, I do not give a mandibular nerve block under a microscope, because, and I'll tell you why so. My microscope is not oriented like that. My microscope is not a 6-step magnification. So you need a 6-step magnification, but this is an upper tooth anesthesia for rubber dams, which we give under the microscope, just to show you how it is done. It is so convenient. It is so easy. Just put a little jelly on the, so this is a circular shot that I'm giving the patient for the rubber dam application. And you can see the patient is absolutely sitting. There's no movement happening from him, because I'm doing it in the right way, the bevel facing towards the sulcus. You can see the blanching happening around. And it is so easy because you're all the time in control. No leakage of the LF in the mouth. Even if it is, I tell the patient a little bit about it. So you can see how the blanching is happening. And there we go, where to place a premolar clamp, because sometimes placing a premolar clamp can be a challenge. In fact, placing a canine clamp can also be a challenge, because the patient tends to really feel the pressure of the clamp. So you must give a sulcular anesthesia before you do these rubber dam applications. Moving on, again, under the microscope, finding the MB2 becomes a joy, because you're looking forward to it. You're all the time looking forward to finding the MB2. Because you want to know, because you know that under the microscope there is a high chance, 97% chance that you will find the MB2. So you learn how to explore the mesial line from the parietal, explore, go with your endo mounts burrs, find the MB2, prep the MB2s, and they're ready for packing. And that's the beauty, is that that's why I said you start becoming more skilled when you are under microscopes and under magnification and rubber dams, because there is no peripheral noise. Your eyes are focused, laser focused on where you want to be seeing and going. Again, one of the recent cases referred, beauty, the joy of working under a microscope, because you can evaluate every step. Failed restoration, when I opened it was non-vital. You can see the hypoids in action with the effervescence. You checking for mid-mesials. One second, guys, sorry. Checking for mid-mesials. Now that's how we check for mid-mesials, remove the overhangs. Just hold on, let me just go back to the same slide. Let me just remove these annotations. Okay. It's fun removing them with an eraser, but guys, please don't do this scribbling on this on screen. Or you can do what you want to do, but that's fine. But still. Okay, here we go. So checking for mid-mesials becomes a joy under the microscope, because you exactly know where you're cutting. Now this is a money U file 25 in action. I had to check for the mid-mesial. This was there was a large periapical in this case, and easy. It's so easy because you're in control. It takes a little time, but so what? You enjoy it part, because you're going to be documenting it, and then you can actually show the patient that each step. So whatever we do, we record. So we told the patient that this is why we were recording. No mid-mesials were found. You found this was a type 2 with a distolingual anatomy. We used AquaCare, a brilliant machine that we bought. I'm so glad I invested money into it, that it really enhances the bond strengths and the bonding protocol. So this is our go-to machine every time, conservative procedure or endodontic procedure, working with AquaCare. And this is the final restoration with Pelodent. This is how it looks. A nice accessory canal filled, and the canals well managed, and the recall. So in such cases, the recall becomes very important. And you know what? Recently, we did a little bit of financial calculations. Our crowns that we do in our practice have gone down. So we don't do much crowns in our practice now. I would say I would be doing, say, about 1 crown in 3-4 days, that's it. We don't do much crowns. We are doing more of, I am concentrating more on the restorative work once we do a good endodontic job. So working, as I said, working with scopes improve your skill set, and I'll show you why. You start saving tooth structure. Now, this is not a rubber stop, that's an access opening. That's an access. This is once the obturations were done. So you can actually see that is it. That's all that you need to do to find these. And believe me when I say so, there are people who are so much skilled working under a microscope that you'll be actually amazed. I'm not talking that you need to make it so small that you end up separating an instrument. No, but as you will grow. So is this my 2018 work? No, it is not. This is my 2020 work maybe. As you will grow in your practice, you will start realizing, you start loving when you cut less, and you will start telling the patient. So sometimes, believe me, about 4 out of my 10 patients would tell me that they would actually look at me with this eye. Did you actually say 14,000 for a root canal? As if they're going to be like really coming up to me and really telling me, is this possible? How can you charge me so much? And I tell them that I'm going to be charging you because I will save you your money in the crown. And when they listen to the whole conversation that, okay, I'm not cutting your tooth more, why do you have to cut more to put a crown back on? And they start understanding the value. Of course, you have to evaluate a case whether a crown is required or not. But that's why I said our crown practice has gone down, but our restorative practice has gone up. And I will only improve with time with newer things. Probably next month we buy an iTero, a scanner, and we start doing more of bonded inlays and onlays. So this is how you will grow and you will start loving your work more. And the patient also now understands. So you're saving them more money if you don't give them a crown. Now, again, sometimes documentations become very important when you're working under a microscope. He's a very famous doctor in Faridabad who wanted to have an RCT done. And I said, look, it is a difficult case. Let's remove the coronal restoration and see, because in such cases you tend to see fracture lines, and that's what we did. This is a Curare caries detector dye, brilliant dye, which I feel you must buy for your practice. You can also buy Sable and Seek from Ultradent, really helps you to do these cases. Not just these cases. So once we removed the dye, we washed, there was a fracture line that we saw. The fracture line did not absorb the dye, and the patient got a CBCT done. We got his crown lengthening done, and most probably next week we start with his retreatment. Yes, the fracture line is there, but it was so easy to communicate with the patient that, look, this is what I'm finding. Once I saw the fracture line, I told this patient, Dr. Neeraj, I said, look, doc, let's go for a CBCT and let's see where this is heading, this fracture line. So it wasn't communicating till the crestal part. He said, let's take a chance. Crown lengthening was done. Maybe when I meet you next time, I can take this case forward and show it to you. I think one of the questions that was being asked in the chat box is, how do you find canals in the sclerotic when you don't feel the drop? And I'll tell you later on for what we do. Again, a difficult case for me because this was an 80-year-old patient. The canals were separating into two. I was a little skeptical on how it may turn out to be. The microscope was brilliant. We started with an access from the buccal side and found the two canals. The lingual was even hard to find because it had to come at an angle to enter into it, which is fine because we use heat-treated files now. I am absolutely in love with the EndoStar files. And the HiFlex files from Colteen, brilliant file systems to use. And with the obturation done, core build-up done, again, not a crown given to this patient. And this is it. That's how it looks after obturation. And again, why this is important, because you try to be in control. Even the glide path that you're making is under your control when you're working under a microscope, because you can actually see the reference plane, the rubber stop hitting the reference plane all the time when you're working. A difficult case, a 70-year-old lady with an irreversible pulpitis, and believe me, that really, really stresses me out when I see a patient with irreversible pulpitis, and that too with referred pain, because it is difficult to get such patients numb. That's the main trick, because if you want to give them a nice experience of how root canal should be, you got to really know how to numb them properly. And these hot teeth are very, very tricky sometimes. So fingers crossed, sometimes numbing such teeth can be a challenge. My go-to anesthesia in such cases is always artricane and infiltrations. So, and also intraligamentary. So this is from where it was. Look how clearly the distal margin is. And you will actually see me excavating for a pre-endo buildup in this. This is again my long carbides in my regular micromotor. I don't have an electric handpiece, but it's you will see the why I put this video is this is how confident you become with your hand movements, and I will not nick the gums which are next to it. And the core buildup was done, as you will see in the next picture. A quick pre-endo core buildup. Look at the axis opening size, really tiny. Want to say, although this tooth had already got a crown, but still now we like to see tiny axes. That is what we want. Post obturation done, bonded, and case managed by EDM. And it was a little challenging finding the glide path in such cases, but then it was managed well. Again, another file system which I would have happily, because this was before I started moving on to EndoStar files, was the EndoStar. And EndoStar file is brilliant in working in such difficult and challenging cases also. Now, you would be doing this procedure approximately 20,000 times in your practice. 20,000 times in your practice. Now, this is how glide paths will become a key to your success. Now, how I've done this little calculation is, on an average, if you're doing, say, 3 glide paths in a day, if you're doing 1 root canal in a day, and or sometimes you're doing 2, so I've taken an average of 3 glide paths in a day, 5 days in a week, 15, then do the maths, and it will come out to be around about this much only. So this is how many number of times you got to be doing this part, this job, and you got to be bloody good at this so that you can nail your obturations every time. So glide path becomes the key in this. Let me just see how much time I have. Okay, glide path becomes the key in such cases. I'm sure all of you are doing glide paths. In the chat box, I will just go back again. Which is your favorite file to make a glide path? Quick answers in the chat box, please. Here I am waiting for you in the chat box. Niti has a very interesting question. What makes a root canal complicated? Everything. Even if you have a wife who fights with you and you have a bad day at home, it makes the root canal complicated. Number 6, Dr. Manish. Neo-endo Oricam, Dr. Manish says, Vaibhav says number 6, fantastic. Any guys, come on, put the chat box on fire. Which is your favorite pro glider? Dr. Aladdin says, nice. Number 10, Dr. Swati says, fantastic. So Dr. Swati would pick up a number 10, Walden, Wallflex. Dr. Kamna, which file involved in? Dr. Shivani Kapoor says number 10, number 10, number 10. Go on. So many people, so many less answers. Quick, let me have a very interesting part because I'm going to be sharing what I do. A K file, number 10. Number 15 file, Dr. Praveen, number 15, fantastic. Number 8, Neo Endoflex. So many answers, so much to pick from the market, so many things. Number 10, number 10, fantastic. Number 8, number 10. I don't know if you're talking H file or K file. A GG2 is Dr. Kamna says. Number 10, Dr. Kajal, fantastic. So I've got your answers going now. That's what you're going to be doing with the number 10 file or a 15 number file. Now, I'm going to be telling you a formula which you guys can write down later on. So I hope you have your pens and paper with you so that you can note down a few things. Why glide path file and why choose HiFlex EDM files? Let me go on a different path altogether. That I will come to a HiFlex EDM file later for that matter. It is important to understand why you want to choose the right path for your glide path. Now, let me go back to the question. जब हम अपने exams में बैठते थे और हमारा final exam होता था और question पूछा जाता था define endodontics. Endodontics है क्या चीज? हम क्या चाहते हैं जब हम कोई case करते हैं? I'm sorry if I'm speaking in Hindi from all my international focus. I was logged in. So what are we looking at when we do an RCT? I'm talking about myself. When I do an RCT, I would look at the X-ray once the obturation is done. If it has a periapical lesion, I would want it to heal after 6 months or 4 months after on recall X-rays. And if I have a patient who has no periapical lesion, no apical periodontitis with pathology, I would not want it to develop. It is as simple as that. You want to prevent or heal the endodontic lesion. For that, you need a successful obturation. For that, you need a good shaping and cleaning. And for that, you need a successful glide path. That's it. So your glide path, actually, let me rephrase it, defines your practice for the rest of your life. If you start loving your glide paths, if you start enjoying making the glide path, everything will follow. That's the whole game. That is what I've learned. And I still get stuck in glide path sometimes. Just because I'm taking a lecture doesn't make me invincible. I will still get stuck. I will still cross my fingers when I do a case of a molar with a little curve. And I will learn from each case, and so will you when you go on. Remember this: slip and slide. Slip and slide. So if your instruments, whatever you choose for your glide paths, are doing slip and slide, that is the secret sauce. A smooth radicular tunnel from the orifice to the terminus, whatever way you want to practice your radiographic terminus or the electronic apex locator, that is your glide path file. A super loose number 10 becomes your glide path file. Now, that is the definition of a glide path. That is how you assess a glide path. But is that the first file you pick in a glide path? I would beg to differ on this, because you can start with the number 6, as someone said. You can start with the number 8, as someone said. You can start with the number 10, as someone said. You can start with the number 15, as someone said. Hey, you can start whatever hell you want to start with. But are you looking at the X-ray? Who's reading your X-ray? What is the file trying to tell you? If you have a patient who's a little adult patient and you see a little bit of calcification in the X-ray, you better not start with the number 15. You might start with the number 8. So the key is to come down to a super loose number 10. That is the key. What you pick up from the endo box is not the key. So sometimes choosing the right file to start is the most important. And invariably, a lot number of times, you would want to start with the number 8 and sometimes a number 10, depending on what you're working with. So this is what you will learn. I can't give you protocols that pick up this file and start. No, because that's not what it is. Because if I tell you to do that, it will vary from case to case. So remember, when a patient comes to you, he's already coming to you and saying, look, in my molar, I have a glide path there. Are you skilled enough to discover it? Or are you unskilled enough not to discover it? So a glide path must be discovered if present, or prepared if not present. Let me make it more easy. A glide path in a maxillary anterior of a young patient has to be discovered. That means you don't have to prepare it, because if you take a number 10 in that patient, it is already there for you given, because that's how the canal system is. So it is already present, you just have to discover it. A glide path has to be prepared in a tough case like I showed, or maybe in one of the cases that you get stuck. That is where you have to prepare it. So you must be able to understand this part, which is very, very important. Now, glide paths is there. The point is, it is never straight. That's the whole trick with it. Sometimes you will get, and this picture is picked from a very old article that by the name incidentally is Grove, Dr. Grove in I think 1923. The very old picture. That glide paths are there. It is just in different forms. A J hook in a maxillary lateral incisor can be an absolutely task to manage. And maxillary lateral incisors are very, very infamous because they have an apical hook going towards the parietal. So you have to understand the glide path will occur in multiple widths, lengths, curvature. They can be short, long, wide, narrow, curved, more curved, dilacerated. So the root canal system is not present. It is not a straight pipe. It's going to be a challenge. So remember, you got to follow it. You don't want to make your own path. You got to follow it. It's like driving from Manali to Rohtang Pass. You have to go on that road to do it. You can't make your own roads in that, right? So this is very, very important when you understand about glide paths. Now there are two types of glide paths. We all know you guys are experienced enough at what you're picking from the instrument set. And I will tell you one formula which you have to write down, that why this formula becomes the key. Now, there are two types of glide paths, the micro glide path, which you are going to make with your hand instruments, and the macro glide path, which you will be making with the rotary files. Both these glide paths are going to help you make a successful, we will help you choose the right file that you pick next from your endoblock. The manual glide path is prepared by K file, and K file for me is the file to be picked up when you want to make a glide path. That is for sure. There's no doubt about it, unless and until it's a calcified case where you want to be working with a C pilot file or a C file from Dentsply. That's a separate case altogether. Now, glide path by a rotary, again, there are a lot of files in the market flooded. You get to see your sales reps in your office every day that this is a new file, new file, new file. Now, the basic thing, I don't want to be boring you, but this is just want to tell you, there are two types of files in the night eye. Now, everyone is on night eye, which I feel. In NiTi, there are two types of files. Are they the Austin type NiTi files, which are your files which cannot be pre-bent? Files which are straight. So if you take a file, a NiTi file, and you flex it and it comes back to its own position, that means this file knows that this is my memory. So this has a shape memory. Now, a controlled memory file is when you bend a file and it is going to be staying like this. That are the two type of NiTi files that you have in the market, to make it very easy for you. A file which comes back to its position all the time, which has a shape memory, is an Austin type file. Basically, it is always in the Austin type phase. A file which is like this, but comes back when you heat it, is in the martensitic phase. Now, there are different files. So someone said a Pro Glider in the chat box. Pro Glider is in the Austin type phase all the time. So if you pre-bend the Pro Glider, it will come back. Few files from Denseply initially are like that. So if you the twisted files from TF, the TF files from Cybron Endo are like that, they will come back to the position. The control memory files are the HighFlex CM, the HighFlex EDM, and one of my new favorites, the EndoStar files, because they are made with a special blue NiTi heat treatment, which makes them remember their new shape. So this is control memory shape. They're always in the martensitic. Now there is a reason why it is important to choose these files for picking up for a glide path, because if you want to be making a glide path file with a file which always comes back to its original shape, you need to start moving on to a controlled memory file, because you will be all the time following a curvature. That's the first part. Second part is files which are in the Austin type, which means which will always become straight. They have shape memory. It's difficult to work with them if it's a 7 of maybe a 4.8 or 4.7 or a 1.7, where the mouth opening is less, because that file you can't pre-bend. So if you want to work ergonomically, and this is what I did after my microscope became a part of me, I started changing my files. So earlier I was with the Pro Tapers. I completely dropped them because they were cutting too much. Under the microscope, you see a giant cut as if a crater has formed. So we just dropped the Pro Tapers, and now we are more with HighFlex EDM and as I said, my new favorite, the EndoStars. Now, watch winding motion is the key. Remember, you can only watch my wind because you have to own the orifice. And watch winding becomes very easy when you own the orifice. Now, there are different ways in which you can own the orifice. Basically, how to make it super loose. Super loose will only be in a maxillary lateral, in a maxillary canine, or maybe a maxillary interior, or an upper incisor, because that's how the working width is so wide in that. But how are you going to make it super loose? First is identify the restrictive dentin. That's the most important part. Sometimes when you have cut very less, or there is a stone that you saw in a few of the videos, you can't find, because every time the file will be hitting the coronal dentin and then the radicular dentin. You don't want to be doing that. You want to be only working in the radicular dentin, not the coronal dentin. And you have to own the first 2/3 of the canal. And owning becomes important. Someone in the chat box said that they pick up a Gates drill. Yes, you can pick up a Gates drill, but not initially. Now, it is important to own the axis. You can use ultrasonics, Longshanbergs. You have to have 2 preps. So calla lily preps, guys, don't have time for all this, but you can Google what is a calla lily prep. Axis opening needs to be like a flower, which means super loose axis opening on the top and constricting basically into the center, because you want to be saving the pericervical dentin. You don't want to cut more. Remember I said you will become more skilled. Pulp stones have to be removed or modified under modification. So judicious use of gates and orifice shapers within the 2/3 of the canal is very important. As you will start trusting your file systems. There are times when I don't want you to be doing that from tomorrow, but there are times when you will learn. You can actually pick up an orifice shaper from EndoStar. You can pick up an orifice shaper from Denseply. These two I have in my package. I absolutely love them. The new one, pick them up and you can just enter into the orifice, because that's how well they are made. They are not going to separate out that easily, because this is what is going to be doing. Immediately you get rid of the coronal. Gates I would not do initially in the first shot, because you have to be very careful, because they have this long thin shank which can separate out. But when you trust your file system, and the best way to do it is, so easy. Suppose you're free tomorrow morning, your patient cancelled up, or you don't have a patient tomorrow morning, pick up an extractor to do the axis opening. Once you feel you've done the axis opening, pick up your orifice shaper and just enter. So what I do is in, out, that's it. I'm not trying to prepare them. I'm just trying to feel one in, one out. That's it. And when I look at under the microscope, the coronal dentine is all taken care of. So just see how it happens, taking care of restrictive dentine, finding the MB2. This is important. Once you remove the restrictive dentine, you can only then start making a nice glide path. Once the dentine is removed, trying to hunt for an MB2. So you can use ultrasonics, you can use long shank moon spurs to remove it. Once you start feeling, you can get a nice MB2 staring back at you all the time. So restrictive dentine is very important for removing these MB2s, and MB2s are there all the time. Now, what is the definition of a super loose? It's very important. For each one of us here, super loose can vary. Super loose is when you tap on a 10 number file, and I'm saying tap, not watch wind. When you tap on a 10 number file and it goes to where you want it to go, the electronic apex locator length or a radiographic length, whatever way you're working with, that is a super loose. That tells you, now believe me when I say so, you can pick up any file system of your choice that you want to be working with. Once you have a super loose 10 number with a simple tap on the head going to length. And that's the beauty of it. Sometimes you don't have that. So a lot of people who have these queries that sometimes it is not possible. M4 handpiece is the one that makes it possible, because M4 will do watch winding for you. It is absolutely safe, very efficient, simple, easy concept. It mimics your hand movements, saves time, and most important, hand fatigue. I know of 2 dentists who are 42-year-old who have carpal tunnel syndrome. So, and I was like, what is carpal tunnel syndrome? Because they were all the time into manual, and that's what they got into. So M4 handpiece completely makes it easy. As you will evolve in your practice, you will realize that M4 handpiece becomes very important in calcified cases when you feel the 8 number is so much, it is holding the 8, someone is holding the 8 number down, and you can't graduate to a 10 number. Because if you come to a 10 number, you file the 10 number is too tight, but the 8 is fine. So that is where the M4 really helps you. I just want to show this video in M4 handpiece, which I think Dr. Priyanka, I think I was sharing it initially. So this is an 8 number, and I was tired of working with an 8. And I knew that 10 number won't help me now, because the 10 would be tight. So you just see, you put the file, attach the handpiece from the top of the file, hold the handpiece with your other finger that is stabilizing it in short amplitudes of 5 to 7 mm at a torque setting of 800 to 1000 RPM. You will start working with this. And you can see how I'm just checking. And once I take out the file, you will see why it was difficult, because it had an apical curvature, which was a little difficult to manage. So look at that curve with an 8 number. And this is what M4 will do. It will make an 8 super loose. So you can divide the super loose. It doesn't have to be 10 super loose. You can do 8 super loose, confident, come to 10 super loose. So when you do that jump to a next file, you got to be very sure that you have done the homework with the previous file. And that is why 15 number file, one of the doctors mentioned in the chat box, 15 number file. Guys, don't ever attempt to make a glide path with the 50 number file. And I tell you why, especially I'm talking in molars. Look, in a maxillary incisor, a glide path may be there with a 20 number file also. Please write it down if you want to. So the thing is D2 minus D1 upon D1 into 100. Now what I'm trying to say is, you use 2% files, which means they have a taper of 2%, which means they're 0.02 increase. So a 10 number file is 0.10 at D0 and 0.12. A 50 number file is 0.15 at the D0. So if you do D2 minus D1, which is 0.15 minus 0.12 or 0.12 into 100, it is 50%, which means when you come from a 10 number file to a 15 number file, there is a 50% increase in the tip diameter. So how many people feel here that when you come from an 8 to 50, the game changes? I am one of those. I had a horrible time. And for the last so many years, we have not ordered a 15 number file, at least new files. We have a lot of stock of 15 because that's what I bought like crazy from Equipment. I don't use them. I have them only for my maxillary interiors, glide paths, that too if it is required. So this is one increase, which is absolutely the key in a disaster. That's a recipe, because if you do that jump, you will be actually doing a 50% jump, and that is where the ledges happen. That is where the blockades happen. Sometimes when you do a 15 number and all of a sudden you feel that 10 is not going back in. Either you've ledged it, or there is a collagen, dense collagen pulp, which has just completely clumped and blocked the apex, and you can't find the apex because the 10 is now not going, you start screwing in, because that is where the patient starts to go. You start feeling tired, stressed out, and that is where the ledges will happen. So remember this part, that please don't graduate to a 15. Okay, even if you want to do a 15, now here is the trick. Take your 10 number file, take your 10 number file 1 mm beyond the apex. Because if you take your 10 number file 1 mm beyond the, and this is only for people who are using apex locators, if you take your 10 number file beyond apex, you will make the D0 as 0.12. So now D2 minus D1 becomes 33%. That's why now 15 number becomes relatively easier. So remember, if you are working with 10 and 15s only, in a difficult case, I'm talking a difficult case here, you would want to take your 10 number 1 mm beyond apex, because that's not going to go, that is what not going to hurt the patient. You just take it 1 mm beyond, the D0 becomes 0.12 now, because D0 is beyond apex and D1 is 0.12. It is easier to take 15 number to length. So remember this, 15 number files are not good, but then if you want to use it, that's the trick. Now this was a case, a very difficult case for me, a tough one. The stones everywhere, there were stones. Difficult glide path was a challenge here, but the trick was the axis. Look under the microscope, the axis opening is small. The trick here is to identify these coronal restrictions to have a successful glide path, and this is how the 1/7 now looks after obturation. It's complete. Didn't want to give a crown to him. So remember, glide path becomes the key. If you understand what is holding the glide path back, where are the impediments? Now, why high-flex EDM files are brilliant? The reason I say so is they are brilliant because they are 700%, guys, 700% more prone to not having fractures or cyclic fatigue as compared to your conventional nitride files. 700%, that's a huge jump. And how they did was, they took the CM wire, which was the high-flex CM in the market, and they did a surface treatment. So EDM is electronic discharge machining, which completely removed any surface irregularities and any cracks on the file, making it more resistant to separation. And they are absolutely brilliant if you want to use them for glide path files, especially the 1005, which is the starting file which you have. So you need to buy just one set, and you need to start using them first on an extracted molar, and then you see the beauty of working with the 1005. It is one game changer. And slowly I have learned another file in my practice that is really has become second skin to me in my endo box, is my EndoStar glide path files. Again, a brilliant system at a very economical price. Now, what is shape memory and control memory, which is very important. This video is very, very important to understand that what is shape memory and control memory, and why these two file systems can actually cause ledging. So this was your pro taper. This video is pretty self-explanatory, that shape memory and control memory is about. This was pro taper gold. This is now in the martensitic phase. This is TF, again, brilliant file, but has shape memory. Again, TF file, look at the flexibility in the TF files, but it has shape memory. EndoStar files, again, martensitic, it has a blue nitride treatment, some magic they have done with these files. And high-flex EDM, again, this is a 1005 file for your glide paths. And 2005, as the file will, this, you can see the magic of these two files. So this is a high-flex EDM, and that's a pro taper gold. So in difficult cases where it is difficult to reach, it becomes very, very easy. So this is the 25 high-flex 1 file, which is very good for your single file usage also. But again, please do it on your extracted tooth first, not immediately. As you give some heat to it, they will straighten up. So from the change, now what happens in a curved canal in this, you will see, if you take a file which has shape memory, it would cut on the outer and start ledging the case. Same with this. And if you start having EndoStar files which are curved, you will see it will follow the curve nicely, not causing any ledges and transportations. Same for pro tapers, although pro taper golds were good, but they used to cut a lot. And high-flex EDMs are even far better because they tend to really have the shape. And when you cut on the outside, that's how the ledge will form and you will start transporting. So when you have to go beyond a ledge, that's another usage of these files. When you're doing glide paths in a ledged case, you can actually pre-bend them beyond the ledge and then smoothen the ledge with this. And you will see in a case. So the advantages of working with this newer nitide, the endostar or the high-flex EDMs are a technique called tactile control activation. Tactile control activation basically is you can actually take the file into the canal without even starting the endomotor. Once it is engaged in the canal, you can then activate it. So it is so easy in calcifications because you can actually take and feel where the file is going without activating the canal. Now this is how it goes, but don't look at the video. I'll show you on a video what is tactile control activation. Just 1 second. I'm going to remove these annotations. And that's it. Thank you. Guys, if you want to draw something, draw a masterpiece, draw a nice piece of art for me, but not this. Now, this is what tactile control activation is. Once you know, now this is 8 number 5. Now, as I said, 8 was loose, which means I knew 10 would be loose also. So 8 gave me a feel factor immediately because it was a parietal. I would take my 1005 here. This is a 1503 from high flex EDM. You can see that white ring there. The file is not activated now. It is just placed, activated, and you will see in 2 strokes, I have hit the length, and that's it. I'm out of it now. That's it. That's my glide path with the 15 is done. 1503 file with the high flex EDM, and same for an endostar. They work like this. The endostar file has a tip diameter, variable tip diameter. It doesn't come in the tip 15, but it comes with 10. This is a 1005 from again EDM high flex. See, just placed it in, no pressure on the head of the handpiece, activated, 2 strokes, and I'm out of it. That's it. I'm done with it. So this is now a glide path ready in a curved palatal in an upper 1/6. So this is the tactile control activation. I can tell you why this technique is there, because the file is heat treated, has a special heat treatment which is making it more resistant to fracture and fatigue. This is the beauty of working with these files. A very difficult and tricky case for me referred to us again in our practice. Someone had tried to do something with this, this was Metapex. They kept on changing the Metapex for the, so this patient came to us after I think 1.5 years of Metapex. We got a CBCT because the canal I didn't know what was happening with the canal, and there was thinning, palatal, dentinal obliterations in the apical third, and I was really doubting myself whether I can find the canal system, although it looks, but it was very difficult to manage this case. So this is how we managed it. We took this video. You can see what I'm doing. We pre-bend a file. You can pre-bend an endostar. You can pre-bend a high flex EDM. Now, this is the central, and it's a central, and sometimes I feel, wow, it should have been easy, but it was not easy. Because every time I kept on hitting a obliteration or a partial ledge, which was created by the previous dentist. So now you see what I'm doing. Watch winding and high flex EDM, because it is pre-bent, it has a control memory. Now I would just switch on the handpiece, because now I have known I've gone beyond that obliteration or ledge. Switch on the handpiece. Now this is a simple Dentsply X-Smart working in full counter clockwise motion. Just put it on the head of on the file. The file gets sucked into it, and there you would see that it is sucked in, and within 2 strokes I am at length in this case. So this is how you can manage difficult cases with these endostars and high flex EDMs. And this is how I made a glide path. There was no other way to make a glide path in this case. Now this is through a microscope, the same case in the second appointment. Once the prep was done, you can see, I could actually see the apex in this very, very clearly. That's the apex, and we're ready for obturation. So you can see in the left, the first, that there was, because it was obliterated, there was a slight curvature. I went into a different direction, then finally found my way with, this was a 10 number file, C pilot, again pre-bent, and that's the obturation of that central incisor. The core endo was done. Sorry, I don't have a picture of that. And now this patient is getting his orthodontic treatment from the clinic. So this is the beauty of these control memory files. One last case before I take your time. I think it's only 7:32. Glide path in calcified canal. A difficult case recently done, referred to us, and tough one, because this patient had class 2 div 2. The CBCT showed that the canal disappears after a while, and the difficult part in this case, all these were red flags: calcification, look at the size of the pericarpal, is the class 2 div 2, because in such cases, angulating the handpiece becomes difficult. So I'm so sorry. I apologize for this. Yeah. So you need to know what you're up against. What are the red flags? Class 2 div 2 is a huge red flag because the angulation of the incisors is completely lingual. And you know you can't just clamp this tooth. You need to have multiple teeth isolation so that you know that there is not, you can see the axis of the tooth. So we marked it with a pen, worked with comet burrs, checked the parallelism, marked at 11 mm as per CBCT, found the initial entry. This is a C pilot from VW. Now this is where gates would come. Now this is tactile control activation with an EDM because I need an initial coronal entry to this file, and that's it. Where I could see that now every time, and then after a while the drainage was established. You can see the exudate coming out. It was prepped till a 425 endostar file. Ultracal was placed. The extrusion always happens by chance. Never do it on purpose. I did not give the patient any antibiotic, no painkillers. After 2 weeks, down packed, back filled. The sealer was Serra sealed, restored with flowable. And as Dr. Varnawal has an article on bioceramics, he can tell you amazing things about it. And now what matters is the follow-up. That's the key in such a case. So thank you for watching. Now remember, I know you're comfortable in your practice. I know you're doing very well in your practice, but some of you want to do much better because if you feel you're good, that's not good for me. That's not good for yourself. Because if you're good, then you can never become great. Because remember one statement which was given by the CEO of Kimberly-Clark. He said, I feel I've become good. But that's the whole problem. Because if I feel I become good, I can never become great. So good is the enemy of great. Remember this line. And the real magic for you guys will happen when you will move out of your comfort zone. And that is actually where the magic happens. And this slide resonates with me. I have never changed it. I will never change it because this is my life journey. And I personally believe that beyond this circle lies another circle and there lies another circle. And this is really, so thank you so much for your time. That's my number. That's my email. Shoot your questions on WhatsApp if the time is less today. And I would try to answer as much as I know from my own clinical practice. And thank you once again for this. And I hope you guys enjoyed it. Signing off.
Thank you so much, sir, for excellent presentation. Huge applause for you. Wonderful, sir. Now I request Dr. Gunjan Yadav, ma'am. And sir, we have some questions also.
Yeah.
Really wonderful session. Enjoyed a lot and learned a lot. Ma'am, please. Sir, we have a questions in chat box. Sir, there's a question. Dr. Anurodh Mishra asked, sir, how to negotiate canal when there's sclerotic dentin not allowed to feel the drop in? Oh, unmute, sir. Wait a minute, sir. Sir, this is for you from your side, sir. Sir, please unmute yourself. This is from your side, not from our side, sir. Let me check again.
Yeah, now I can. Thank you. So the host
Okay,
was
sir.
not allowing, and I'm not
Yes,
fluent with sign language. When I was small at 2 o'clock on Samachar DD News, there used to be a news for all those sign language. I don't know. Go ahead. The first question. Go ahead. Yeah.
Okay, sir.
Sclerotic canals and glide paths. Is that the question?
Yes, sir.
Yeah, okay. So there's a crazy wedding happening outside my house. God bless the bride and the bridegroom. So if you hear some crackers, that's not in my house. All right. Sclerotic canals and glide path, very difficult situation that you can get into, but the trick is the irrigation. If you have a sclerotic canal, you need to change. So what is sclerotic canal? basically means less of organic and more of inorganic, which means you need to be irrigating more with EDTA. So in such case, you need to have a pre-endo done. Now, why pre-endo? You want the cup filled with EDTA when you watch winding with a number 8. Now, if you have done everything and you still can't go down, that's situation number 2. In that case, you need to come to a endo glide or a glide from Dentsply. The reason I say glide from Dentsply is because it actually helps maintain the pilot hole in which you're working. So remember, don't use glide in all your cases. It's an expensive product. Why waste that money? Buy a decent EDTA bottle from any. I use from Vishal Dent Care in Ahmedabad, but my hypo is from Colteen, 5.5% full strength. So in such cases, EDTA liquid, watch wind with 8. Situation number 2, you've done everything right, you still can't go down. Use a glide path, a glide from Dentsply. It's a viscous chelator. It helps you go down easy. Situation number 3, this also doesn't work. Come to a C pilot file from VW or a Dentsply. Situation number 4, still can't go down. Give a pre-bend, a little tuck on the apical part of an 8 number or a 10 number, and don't push, because you will find a sticky spot as if your file would get stuck in a mud, and then you watch wind and go down. Remember, if you're not able to find the glide path, and if you feel by pushing the glide path, by flexing your muscles, you can find the glide path, you would create a disaster. So do these steps. Remember to pre-curve the file apically. If you give a big curvature with your fingernail, the file will not pick up the curvature. So try to give it with a nail at the tip of the file. And most important part is have patience, because then you need to tell yourself that, okay, today it is only about mesiobuccal, not about any other canal. Divide the appointment and take pride in telling the patient that you have a difficult case. So I would take time on this. So these are my 3 strategies I would do, and trust me, they will work for you. The trick is if you don't push. If you feel you're not able to find a glide path and you push, that's it. You would never find a glide path in such a case. So hope it answers the question. Fire it at my WhatsApp. I'll try to answer it more in a more detailed way. Any next question, please?
Thank you so much, sir. Sir, there's a question asked by Dr. Surya. How to identify apical transportation on RVG X-ray?
Tough one. You can't. Sometimes you can't. No, I don't think you can, because an RVG is a 2-dimensional. The transportation is 3-dimensional. Sometimes you can't see it. The best way is if you get stuck. Suppose you were able to follow to length. So many times I get this query from dentists that, sir, we were able to follow, but now all of a sudden I'm not able to follow. So the best thing to do is take an X-ray at that time. Because when you take an X-ray with that file, and it most of the time happens with a 50 number file. So when you take an X-ray at that time with a 50 number file, you will actually see where it is stopping. Mark it on the rubber stop. Keep okay. At 16 mm, I was not able to go down. So take a 8 number or a 10 number, pre-curve, and once you're about to reach that 15 or 16 mm, curve it away from the direction and then try to find. That means you are going away from the ledge or the transportation part. It is difficult, it takes time, but it is not that difficult also. That is what I'm trying to tell you. It is all about patience. That is the best way. Sometimes an 8K or a 10K would buckle. When you take it out, you feel the file is bent. Please throw it away. Don't use it. Take a stiffer file like a C pilot, pre-bend it, and go from the ledge to the other side by pre-curving it. Remember, if you give a big curvature on it, you would not know where you have gone. You're not following. You are trying to follow the canal by making a big curvature. So you have to follow what you're getting. Even in a transportation, you have to follow where the transportation is. जब हम गाड़ी चलाते हैं और सामने को आता है, हम क्या करते हैं? स्टीयरिंग को हल्का सा लेफ्ट लेके चले जाएंगे. Same way, हल्का सा लेफ्ट फाइल के साथ, and then you will be beyond transportation. It's a game of patience, nothing else. Next question.
Thank you so much, sir. Gunjan sir and TP Chaturvedi sir is with us. Sir, any comments from your side, ma'am?
I'm so sorry, sir. All those sirs, Gunjan ma'am, sir, please just give me a moment. There's a very important question here from Mukesh. Sir, many times endosar files after using 2505, we are not able to go to 25.4 GP. Fine. I don't even go to 25.4 GP. I would go to a 2004 GP, and then I will obturate at 2004 GP. The reason it's important to obturate with a lesser GP in this case is, and I'll tell you why. Imagine a 2505. Sorry, okay. Priyanka, can I take 2 minutes because this is an important question? It is
No
beyond
issue, sir. Okay, carry on, please.
Okay, guys, listen. Thank you. Listen to me what I'm saying now. You prepared with a 2504, which means a 2504 gutta percha will be a snug fit, which means it will be a tight fit. That means when you want to do passive irrigation, that means passive irrigation with your GP, you can't do it because your GP would be too snug to do the irrigation. So always when you do the passive irrigation, that is the manual irrigation with the GP, do it with a 2004, which will be loose in the canal and which would actually let the hypo go down and come up once it is excess. So in such a case, I would absolutely obturate with a 24. If I prepare with a 25, I never even look at a 2504 gutta percha. So that's what I felt was important. So thank you.
Thank you, sir.
Yes,
Sir, yes, sir.
Dr.
yes,
Aladdin has a very sorry, sir. One question, and I will be quiet. I'm a teacher inside. I love teaching. I used to teach. I can't stop myself. Dr. Aladdin has a very important question, and my answer is very interesting. Dr. Aladdin says, when can we update to the microscope? Dr. Aladdin, when you rub that genie from the Aladdin, you can update to a microscope. You can update to a microscope the day you decide to rub that genie, and that genie is sitting inside you. Rub yourself, let the genie out, buy a microscope, and contact me and help you as much as I can. Thank you, and I'm quiet now.
no, thank you, Dr. Rahul. You have nicely explained everything. And there's any new practitioner. Just this is my question. You have excellently presented the topic. There's no doubt that a lot of the new things are well versed with the audience, and you have maintained your audience number. That is a very good thing for your speaking time, always 96 to 100 or something like that. And you have maintained your audience, have not left you in between. That is the problem of the main speaker. You are a testified number one speaker by your bonding of your audience during your conversation. One thing is that just I am not a practicing endodontist, I am orthodontist, but being a dental surgeon, I am associated with the idea and all that things. What is your things that any BDS person just start to practicing endodontic? Because a lot of the things are now the changing. The game is changing from that is just every day go to there and they will extract the tooth and then place the implant. That is more easier way to do and all that things. By using optical microscope and all that thing, it is very difficult for the BDS person, BDS dental surgeon. So what is your suggestion for endodontic practice for the dental surgeons? Because they cannot purchase immediately a optical microscope and all that things. So being an IDA person, it is my question from you that you give a suggestion for the new practitioner and new dental practitioner who used to do endodontic restorations and all that thing.
Okay, so very good question, because this question is how I was. This question is, I think you're asking not this Rahul, but a Rahul 5 years back. First thing is invest in some form of magnification. That is the first thing. You want to buy a phone, don't buy the phone right now. You want to invest in your SIP, don't invest in the SIP, but buy a magnification. It can be anything. Buy a loop which is for 10,000. If you buy a loop which is for 10,000, you will work around it. My first loop was in my second year MDS, which was for 5,000 from Expedient. But there are very good, decent loops now available, because first thing is, when you have magnification, it opens a new era of your practice. That's the first tool, and it is a must, and I must say. Second, sir, please, they have to work under rubber dams. Now, I would request Dr. Priyanka to have to arrange another session with rubber dams. Rubber dams is the key, and it is a quiet taste. It is like having red wine for the first time. Once you have it, you don't like it, but once you have it the third time, you start loving it. That is the key with rubber dams, because if you have rubber dam and magnification, your journey has started. yes, you can't run a 21-kilometer marathon, but you can definitely run a 5-kilometer marathon very well. And that is only because you will be doing the right steps. The third inventory, which a new practitioner must have, is friendship with old practitioners, because they can go take extracted teeth from them and practice few certain things, like working with NITI files, heat treated NITI files. Now, in my opinion, EndoStar files are value for money files. Absolutely, I will not deny the fact they are value for money files. Within 1800, or I think in 1950, you get files which will last you for at least 3 cases. I'm not saying they will not last you 4 cases, but in my practice, we have EndoStar files which are disposable. We'll use it once and throw it. So, but EndoStar files are a must-have because they're super heat treated and they're easy to practice. And sir, training on extracted teeth is very important, and not have too much inventory. मैं ये भी ले लूं, मैं ये भी खरीद लूं, मैं ProTaper भी ले लूं, मैं Oricam भी ले लूं, उसके पास है, ये नहीं करना. These are tried and tested files. They will really sort out the endodontic part, and of course, RVG and apex locator is a must to really remove the doubts in your practice ki length pe hu ya length pe nahi. That is only answered if you have an electric contour. And these are very basic equipment. And sir, I must say that these are the norms now. If you don't have it in your practice, you are a dinosaur. You will be eliminated by the competitors. So these basic tools, which will not cost you more than 2 lakhs, are a must in a beginner's practice now, in today's time.
Thank you, Rahul. Well explained. Yes, Dr. Priyanka.
So many questions in chat box.
Guys, if whosoever is tired wants to leave, happy to leave, but I would want to answer the question because I will not be doing justice. Which file system is the best for thin canals? Dr. Priyanka Solanki asked, and I would want to ask Dr. Priyanka back. Priyanka, what do you think, which is the file system? There is no file system which is best. There are many systems which are good. There are many systems which are not good. You please remember, times have come where people want to cut less, which means save the dentine, and you can only save the radicular dentine if you're cutting with lesser taper files. So I would say Pro Tapers, if you really want my opinion, Pro Taper Golds are a no-no for me because they cut too much. They remove so much. And the most important part is that one S1 of Pro Taper takes so much time to cut that a lot of people tend to separate that S1. So if you ask me, in a thin canal system, I would be between a 420 and a 425. If it's a sclerotic canal where I have negotiated with 8, my glide path has come with 8, I will stop at 420. That's it. I don't have to take it to 425. वो time चला गया कि 3 size ऊपर ही file खत्म होगी master apical file. अगर 8 से शुरू किया है तो 10, 15, 20, 25 ऐसा नहीं होता. So if I'm starting at 8, I would finish at 420 and I would obturate at 415 gutta percha because I want good passive manual dynamic irrigation with my gutta percha. So that is my answer on which file system is for thin. Should we place EDTA gel in the canal for 2 to 3 days in case of calcified canals? No, it doesn't help. That is someone has told you something wrong. It doesn't help at all. EDTA is not. It doesn't work like that. So don't do that. Don't do this, please. Good you asked this question because these are the doubts that people have. Sir, what is the perfect magnifying power for instrument removal? It depends on what you have in the microscope. If you're working with a good high-end microscope, you will want to retrieve it at 20x because even a slight movement of your hand, you are out of focus. So the higher the mag, generally the highest magnification is for documentation. So in my microscope, which goes up to 2.4, 2.5x, you can say 25x, I would be working at 16x for instrument removal. It all depends, can you see? If you can see the file system, you can remove the file system. So there is no single mag, ispe nikal sakta hai, ispe nahi nikal sakta. Any good book on endodontics in simple language? No, there is no good book on it. All books are complex for me. It's your experience which makes you read a book. So just read the basics of endodontics from Cohen or whatever these new books PGs are reading. They're all good books. Which loops to buy? If you have the money, please invest in Heinz loop from the company Dental. This is a Heinz. It is an expensive loop with the headlight, but I'm telling you today, mark my words, it will change your practice if you invest in a good loop. Should we start with loops or we can go with a microscope? It is your choice. If you want to become uncomfortable and yet become comfortable by a microscope, but you have to see the finances, you have to see the space that you have, and then you have to this thing. But in my opinion, you should start with the loop now, and then in 1 year tell yourself to. So it is like driving a Maruti before you come to a BMW. My question is, when should I update from old microscope to new microscope? Dr. Aladdin, you need to pull out the genie again, because coming to a new microscope, like I want to now come to a new microscope, so I don't have the genie inside me because I'm out of cash right now. But it's a personal thing. You can decide when you want to upgrade to I feel when you're not able to document a case properly, that is the time when you should be thinking of a newer microscope. Thank you, sir, Priyanka. So that's the end of me, I guess.
Thank you so much, sir. Dr. Varnawal sir is here with us. Sir, any comments?
Wonderful
Sir, he is the
lecture.
professor from Endo.
A wonderful lecture, Dr. Rahul Grover, and tell detail about the glide path and on the magnification. And definitely this will be very helpful to the audience. And even every step in the endodontics is very, from diagnosis to end obturation, and even post obturation there will be restoration. Every step is very important, not only the magnification. Any step you failure, that will means your endodontic is a failure. Thank you, Dr. Rahul.
Gunjan ma'am, please, your comments.
Yeah. Dr. Rahul, I should really congratulate you. It was a wonderful presentation. Very beautifully you explained about the microscope, the ergonomics, and the glide path. Yeah, I still remember when I went to do the course on the microscopes in Delhi, Dr. Kunal Gupta kya, I really felt that what we are doing from the naked eye and under the microscope, it's a huge difference. ऐसा लग रहा था that there is a khai. We are going inside it. So it's really beautiful. And I would encourage all the passing out students that they should start with the loops and then proceed with the microscopes. So it was a beautiful lecture and very nicely explained everything. Very nicely explained. Congratulations to you. Thank you.
Thank you, ma'am.
Yeah.
Sir, there's, I guess, questions in chat box again.
Yes, sir. Dr. Rahul is explaining beautifully all the answers.
Yeah.
I mean, you really have the patience after speaking. You are answering all the questions. Hats off to you. Great.
Yeah, thank you, ma'am.
Sir,
This is me completing my void of teaching. This is me. Otherwise, I still tell my wife, I wish I can go back to college to teach, but colleges have changed in today's time. Cases having separation of file in the apical 1/3, tell me next what to do. Should I extract or should I obturate? Hey, buddy, it's a tough one. Do you have the courage to tell the patient that this is there, that, hey, there is a separated file in the apex? I hope it is not done by you, but even if it is done by you, you got to own it up. And so in this case, if the patient is asymptomatic, there is no periapical pathology and there are no symptoms of periodontitis, you can obturate the case, provided it is a written consent that yes, it may backtrack, it may fail, and you might have some discomfort. I have seen horrible RCTs, horrendous RCTs, under extensions, if what I may call it, successful. So you never know if you're lucky. If you're lucky, then God bless you for that. Dr. Mukesh says, in winters, resin-based sealers get thickened. How do you manage that? It is a very easy question because I don't use resin-based sealer. I use a bioceramic sealer, CeraSeal. I don't work with resin-based sealers now. I've never worked with AH+. I feel they used to cause more apical problems with even a slight extrusion. But I think time has come, and Dr. Vanwal would agree with me in his book that he would have written, that times have come to upgrade to a bioceramic technology, and that's a game changer. How's Lambert's microscope? I'm sorry, Dr. Kulbir, I don't know about Lambert's microscope. I have a Labomed, and I'm happy to share all details of that from where I got. It's a good microscope. It's a good beginner's microscope. Let me put it like that. It's not a high-end microscope. If you want to invest in a good microscope, you can invest in a CJ Optics or microscope, or you can go for a micro, this one, the Zeiss one, provided you have finances for that. But Labomed is a perfect microscope to start your journey. Perfect journey. Yeah, that's it. Those are questions in the chat box, I think.
So much,
Dr.
sir.
Priyanka?
Yes, ma'am.
I would like a minute, and I would like to thank even Dr. Rajkumar for getting me on this platform. Thank you, Dr.
Definitely, ma'am.
Rajkumar. Yeah, I mean, I missed out him, but I really want to thank him to get me here on this platform. Thank you, everybody. Thank you.
He's the backbone of our team, ma'am.
Yeah, and he really made me come here, and that's
And I must say thanks to Dr. Kapilgar, sir.
Yes.
Actually, sir has suggested me Dr. Rahul Grover, sir's name.
Yeah.
Yeah. Enjoyed a lot, sir. You're really wonderful, sir, presentation. And next time we'll come again with some other topic with Dr.
Rubber
Rahul
dams,
Grover.
if you ask me, rubber dams is the thing. We have to come to rubber dams. That is the only possible
Sure,
if you can do.
Sure,
yeah,
sir.
rubber
Sure,
dams
sir.
is the yeah.
Sure, sir. Thanks
Thank
to
you, guys. Thank you so much.
all participants, our mentor, and our guest, especially Dr. T.P. Chaturvedi, sir, Dr. Bernal, sir, Dr. Gunjan, ma'am, Dr. Kapilgar, sir, Dr. Nikhil, sir, our team, Dr. Rajkumar Singh, sir, Dr. Surya, Dr. Arpita, Dr. Deval, and all participants. Thank you so much.
Thank you.
Thank you, Dr.
you,
Priyanka, and all the best for future.
Thank you,
All the
ma'am.
best for future.
Thank you, sir.
Thank you. Thank you, everybody. Thank you.